because we have an unbelievable closing speaker today, and I wanted to introduce you to Dr. Natalie Coburn, who is a senior surgical oncologist at the Sharif and Mary Lou Hanna Chair in Surgical Oncology Research, which is quite a mouthful, I might add, at Sunnybrook Health Sciences Centre, Toronto. She is also a professor of surgery at the University of Toronto. Dr. Coburn has held several leadership roles, including head of the Division of General Surgery, chief examiner for the Royal College of Physicians and Surgeons of Canada's Surgical Oncology Fellowship Examination, founder of the Canadian Gastric Cancer Association, clinical lead in patient-reported outcomes and symptom management at Cancer Care Ontario, as well as her most recent appointment as platform director at Evaluative Clinical Services at Sunnybrook Research Institute. When we were preparing for this discussion today, Dr. Coburn talked about her passionate dedication to making research more patient-centric, driven by some of the personal experiences I know that she's going to share with you today. So I think it's very fair to say that she puts patient voice, patient perspective, patient needs at the very center and heart of her scientific inquiry today, and that's why this is very important as part of the future of research. Dr. Coburn.
Thank you. I'd like to thank Barry and Carol and Anne-Marie for inviting me to speak today, and thank everyone for sticking out to the end of the day. The only thing that's worse than being the last speaker before lunch is being the last speaker before the end of the day, and everybody gets to go to the bar and to dinner afterwards. So I'll try to keep this engaging. I suppose these are a little bit of disclaimers that I have to say. I am the clinical lead for patient-reported outcomes and symptom management at Cancer Care Ontario Health. As the day was going on, I did amend some of my slides, and the AV team was kind enough to pull up a second slide deck for me with a few amended slides and some comments that Linda had prompted a few changes of slides. I'm also a director for ECS at Sunnybrook Research Institute, and wearing that hat, I work with all the clinical trialists. I am not a clinical trialist. I'm just a real-world outcome researcher like Kelvin and Winson. So, patient engagement. Here is a lovely definition that I found, which says the active, meaningful, and collaborative interaction between patients and researchers across all stages of the research process, where research decision-making is guided by patients' contributions as partners, recognizing their specific experiences, values, and expertise. And this is International Society for Health Economics and Outcomes Research, which is a great real-world evidence group. And I like this definition. I really thought it embedded everything that I wanted in this definition. And the second reason I like it is because of the way they came to this. So they're real-world evidence folks. They research things. So in order to come up with this definition, they did a systematic review, because that's what we do. They had 1,800 abstracts, 317 full-text reviews of manuscripts. There were 244 distinct definitions, and this was only over like a 6 to 7 year time period. And then they created a statement, and they vetted it with patients, industry, and academic stakeholders. They talked a little bit about their research, and in those 244 definitions, the top characteristics of activity was patient as a participant. It's not patient as engaged or patient guiding research, it's patient as a participant, and then patient involvement, which I think means patient as a participant, and then patient preferences, and then you come down to number 5 or 6, patient as a partner, active process. So you really get down into the single digits before you get to the point where I think everybody in this room wants to be, which is patients engaged in the research process. When they talked about the stage of activity, the top one was the last thing that happens in practice and the patient as a participant. And then number 2 is undetermined. We couldn't tell how the patients were involved. And then the third one down was design and planning. So I really thought that a lot went into this. This was published in 2020. If you look in PubMed, the number of publications for patient engagement, it starts out fairly low. It actually only starts going up over the recent 10, 15 years, and now there's about 3,000, 4,000 publications a year. So what work is that as our definition? So I wasn't really sure why I was picked to talk here today, because I'm not a trialist. I'm a real-world evidence researcher. I'm a surgical oncologist. I do colon, liver, gastric, pancreas surgery, and then I do ICS outcomes. And I'm going to talk about my journey. I'm going to talk about some of the things that I've done wrong. I'm going to have a very honest conversation here about things I wish I'd done better, and then how our group is working now. And mostly I'm going to talk about how we engage patients better and more as our process has gone over the past 2 decades. So where'd she go? Where's Sarah? I'm from UNC. There's Sarah. Sarah's from Duke. If anybody knows anything about NCAA, Sarah and I shouldn't talk very much. So I was at UNC for 8 years, and then I moved to Brown. I wanted to be a surgical researcher. At that point in time, surgical research in the US was largely based in laboratory work, and I wanted to improve patient outcomes. So I did my master's of public health right up the street from Brown at Harvard, and kind of broke from the usual US mold of a basic scientist surgeon research model. I came to Toronto for the U of T fellowship in surgical oncology, and then Sharif Hanna offered me a job, and I stayed in Toronto. And so I'm actually American, not Canadian, but I've been at Sunnybrook since 2006. So if you could define what my mission statement is, it's to improve patient outcomes. And that's why I studied surgery, and that's why I studied at Harvard, and that's why I stayed in Toronto, was to improve patient outcomes. And the way I thought starting my career to improve outcomes is to study it and to find out what went wrong in the process, to improve the process, and you know, you publish and you talk to enough colleagues and things will get better. And so I studied survival and access to care and the way things happened. I've studied cost and quality of life, and then finally got to a point where you have to study human factors, education, understanding, and what drives people to do what they do. The main population I work in is cancer. I'm a bit of a data nerd. That's probably what drove me to be at Sunnybrook. So I like big data. So I work at ICES, and ICES is fantastic because it has a lot of what Winston was talking about. You have the hospital level data. So we know the hospitalization. We know how long the patient was there. We know if they got a blood transfusion. I can tell the chemotherapy that they got in Ontario. I can tell the doses of radiation. I can say how much the physicians charged. We can't really get down too much to that molecular issue at the bottom. And more recently, I can talk about how the patients feel about their care. And we talked about this quote earlier today as well. If you cannot measure it, you cannot improve it. Corollary is not necessarily true. If you measure it, you don't necessarily improve it. And the reason everybody's here today is because we want to measure it and then improve it. And so if my mission is to improve patient outcomes, my methodology is big data. That's the way I started out. I've really veered more into qualitative methodology, provider surveys, consensus conferences. Very important to bring all your stakeholders together, medical education and patient engagement. And the reason you need this qualitative methodology paired with your big data is because we know that the gap between what we know as a scientific community and what we practice as a clinical community is very wide, and the average length of time between a scientific discovery to putting it into practice is 17 years. And that's really just too long. So really, these consensus conferences are hugely important in terms of shortening that gap and getting knowledge into practice. So, when we look at improving outcomes, I've worked with a huge team of really fantastic scientists, and most of these folks are surgeons, looking at outcomes from the hospital level, looking at provision of chemotherapy and radiation and access to care and how it's very different for different patients across the province, looking at the cost of providing care and the ways we can do things more cost effectively or less cost effectively, and you'd be surprised at how few people are actually really interested in that. And then finally, we'll come down to this last issue, which is patient-reported outcomes. One of the things that you don't see in this slide is patients. This was kind of the time where we were doing the research. We would do what scientists do, which is go to a meeting and stand up at a podium or put up a poster that 3 people walk past, and then you publish your paper, and maybe somebody reads it and maybe somebody doesn't, and maybe you take it to a patient advocacy group and say, here is what we did. Aren't you proud of us? Not very many patients involved at this time. So in a parallel universe, that was probably about the first 10 years of my practice, in a very parallel universe, things were happening at Cancer Care Ontario. And I didn't work with Cancer Care Ontario at this point in time, but I can say they were doing some really thoughtful, really amazing things. So in the late 1990s, early 2000s, one of the things that they recognized was we don't do a really good job as a cancer system managing patient symptoms, and we don't really do a good job as a cancer system managing end of life. And those are 2 key things a cancer system should try to do well. And so they recognized that, and they put programs into place. And so I can't really take any credit for any of this. But the palliative care network was established in 2005, and symptom management was identified as a big problem in 2006. So ESAS was actually introduced in 2007, so they moved things along very swiftly. And so if you want to understand the PROS situation in Ontario, you have to understand how it started and why it started, and this is the genesis of it. So it was actually trialed at Queen's as a single site over a few months. Everyone at Queen's loved it, and it moved into the entirety of the system pretty rapidly. So they built their own infrastructure, which is the ISAC infrastructure. ISAC infrastructure is fantastic because it makes the data sharing between the regional cancer centers and the non-regional cancers fairly seamless, and it allows the same survey to go out to every patient. So whether you're treated in London, or you're treated in Toronto, or you're treated in Ottawa, or you're treated in Moosonee, you get the same survey, which is fantastic if you want to compare across patients or if you want to educate across a system. All that data goes back into Cancer Care Ontario. We'll talk about what they do with it in a minute. A psychosocial oncology program was started in 2008 in order to support all these symptoms that we were finding that patients were having, and additional proms were added. So we're working with a PHQ-9 because ESAS screen, as we know, is a very superficial screen. It's not really good enough to really come up with a validated measure of depression. And then there are some things that ESAS really doesn't work well for, like prostate cancer. So EPIC was instituted in 2017. I started my job with CCO at late 2018-19, so right at the end of this slide. So this is all work that Lisa Barbera did, and she's currently in Calgary. So how do PROS work, and why did Cancer Care Ontario decide to do this? So PROS work by asking you to score your symptom on a scale of 0 to 10 or 0 to 9. So how are you doing today? And score it for us. And this is what's really important, because if you don't ask patients to score it, they actually don't tell you as much as you need to know. So this is what we ask for ESAS. This is the ESAS form. It's Edmonton Symptom Assessment System. So this is clearly what's used in Alberta, and it's used very well across the Alberta Health Network. And it scores general things. This is a generalized screening form. This is not get into the weeds nitty-gritty. This is generalized, how are you doing? And at Cancer Care Ontario, it was started as a point of care issue. This was meant to empower patients, and this was meant to start discussions. This was not meant for research. This was not meant to evaluate how systems were doing. This was not meant to do much other than have a sheet of paper that was passed between the patient and the provider, and then the provider would look at it and say, I see your pain score is really high today. What can we do to make this better? And Cancer Care Ontario and the folks at Cancer Care Ontario who don't work in the trenches like I do honestly think that we have time in clinic to have this moment. Unfortunately, this moment doesn't happen that much in clinic, but they really did think that this would empower patients and empower the discussion. Now, the reality of what happens in the cancer center, as we all know, is very different. We are talking about EQ5D earlier, and there's nothing that I would love more than to put EQ5D onto ISAC. But EQ5D was never meant to be on ISAC because EQ5D does not initiate this type of conversation. EQ5D is great for the system to evaluate how things are being provided, but it's not, if I have a score of 75 versus 97, it doesn't allow the clinician to sit down with me and say, why do you have a score of 97? That doesn't make any sense. But why do you have a pain score of 5? Why do you have a depression score of 7 today? What's going on in your life? That can help have the conversation start. And that's what ESAS is meant to do in Cancer Care Ontario. So that's why it is ESAS and not EQ5D. If anybody wants to put EQ5D onto it, I can help, and I would love to have it there as a researcher. So the reason that PROS work is this is the underpinning of PROS, is because if you walk into a clinic and say, how are you doing? Everyone says the same thing. I'm fine, not too bad. Because they don't want to burden the healthcare system, because they know the healthcare system's burdened, they know you're already running 2 hours behind, which is what Kelvin Chan and I were discussing at lunch, and they know you don't have time to listen to these issues that they have. If you ask them, please score from 1 to 10 how you feel today, they'll tell you the blue bars. The blue bars are how they're really feeling. And you can see for mild, moderate, severe, and even highly distressed patients, if you say verbally, how are you doing, they don't tell us because they don't want to burden the conversation. They want to talk about the surgery and the chemotherapy and what happens next and what was the CAT scan result and how's my hemoglobin, because that's why they're there to have the conversation with the physician. But as a system, we need to know the rest of it, and if we're going to support the patients well, we need to know the rest of this. Now, since Cancer Care Ontario has put this into place, and Alberta has put this into place, and it's gone into the rest of the provinces, there's actually more evidence that this works. Now, if this was a drug, this would be a blockbuster drug, right? So usual care is the blue line, STAR, which is very similar to ESAS, is the yellow line. This is a study from Memorial Sloan Kettering, looking at randomizing patients to either nothing or STAR or basically ESAS. Percentage of patients who come to the emergency department goes down. Whose hospital doesn't want that? The percentage of patients who are alive at 5 years is higher. This is a set of metastatic patients. They have metastatic cancer. They survived 5 to 8% more if you ask something like STAR or ESAS versus usual care, which was don't bother asking. How did they do this? They kept patients on chemotherapy, and the reason they kept patients on chemotherapy is because they intervened. So this is the key thing that we're not really good at in Ontario because we don't have the resources. But if a patient has a high score and then you intervene, give them a fluid bolus, change their antiemetic, do a dose reduction, something like that, you can keep patients on chemotherapy longer. They feel better, which is the bars, and they can go to the emergency department less, which is the top graph. This is something the system should want, but we don't have the resources to have that second step in place. PROS have expanded through Cancer Care Ontario because there's some places ESAS doesn't work. ESAS does not work for early stage prostate cancer. Completely different set of issues that men with prostate cancer are having than are you tired or depressed. Head and neck cancers have a very specific set of symptoms. So there's a specific head and neck problem. And then, as I said, we would like to expand depression with PHQ-9. So how is this being implemented and how is this being collected? Well, in 2007, this was paper collection. And so, the way it works now is heavily based on the way it started. And so it started as pen and paper, and then the cancer centers actually had somebody who was entering it into a database to send it back to Cancer Care Ontario. 2015, 2016, 2017, kiosks came into the cancer center, so you could key it in, and then the data went straight to Cancer Care Ontario, and then it comes straight back to your EMR, which has pros and cons. So the beautiful part about it is you don't have to have anybody in the background keying it in, but the bad part is you lose that sheet of paper. So you lose that, here's my sheet of paper, let's talk about my symptoms moment. And you have to have a physician who goes to the EMR and finds the patient-reported outcome and then has a conversation about it. This all is still contingent upon the patient walking into a cancer center. So we talked about the goods and the bads of COVID. So one of the goods of COVID is it pushed people into high gear to get a home-based system for their cancer center. It always existed. We just didn't know how to best utilize it. And we were having those conversations in 2019, interestingly enough. How do we collect this data from home and then appropriately support the patients? So that has been pushed forward much more rapidly than it would have before. But with all of these, it still depends on somebody, a clinician, a nurse, a social worker on the other end, collecting the data and then intervening. Otherwise, why are the patients doing it? And the patients are not doing this to collect data for Natalie Coburn to use in her research studies. They're doing it to have a conversation about their symptoms and to improve. In addition to cancer proms, there's orthopedic proms. So for patients who are having orthopedic procedures in Ontario, this is hard baked in. This is very similar to the UK system. It's actually the Oxford Hip and Knee Scales. EQ5D is in here, and then some general questions. And there's points where the patients have to do their proms. This is much more meant to look at the type of care that we're providing, and you don't necessarily have that moment between the orthopedic surgeon and the patient. How's your knee function today? How's your range of motion? This is being collected more centrally to look at the care that we're providing. There's also proms for congestive heart failure, renal trauma patients, multiple other things coming down the pipeline, and Ontario Health is going to have to figure out how to integrate all of this. The other half of the CCO platform is symptom management, and there's a tremendous number of symptom management guides that we work on, translate into multiple different languages to make sure that the clinicians at the cancer center have the ability to support the symptoms that we're receiving information back. And I'll tell you, when EPIC came out for prostate cancer, one of the big issues was there aren't that many sexual dysfunction clinics across the province, it turns out. Most hospitals do not have the ability to support the questions they were receiving answers to. And so it was a great idea to put that prom out, but the ability to support patients who are having difficulty was not there. And so there's a lot of education that had to go into that. And there was a little bit of a scramble at the last minute because complaints started coming in. We don't know what to do with these answers. We don't know how to support these patients. And certainly there's a lot of symptoms there. So back to my raison d'etre is to improve outcomes. So we started looking at patient-reported outcomes. And the way I started looking at this is ESAS came into the cancer center, and I talked to Calvin Law, and I said, hey, what does Cancer Care Ontario do with all this data? That's a big data set. That's a nice set of data we got there. What are we doing with it? And he said, I don't know. It just goes to Cancer Care Ontario, and then no one ever sees it again. I said, we should look at that. He said, talk to Lisa Barbera. So I did. So we started writing a series of small grants to look at the Cancer Care Ontario data, and then it came time to get a bigger grant, and I don't see the folks from CIHR anymore. And when it came time to get a bigger grant, we went to CIHR, and one of the key things in that grant was, how are you going to engage patients? And surprisingly, we had never really engaged patients before. And part of the reason we engaged patients was because it's the right thing to do, and these are patient-reported outcomes, and this is symptoms, and so it really made sense. And part of the reason was because this was part of what we needed to do to get the money. So, when people follow the money. So if you create the funding opportunities correctly, and maybe it does start with a checkbox, but then often people flow to it because it's the right thing to do. But we went to the CIHR website, and lo and behold, there's a tremendous amount of information about patient engagement and how to do this. And so we're researchers, and we set about researching how to do this the right way. I don't think we hit the mark there, but we tried. So I'll tell you how we did this in 2016. So 2016, the CIHR and CIHI say the reason you should have patient engagement is to improve patient health. Good. Improve access to the healthcare system, get the right treatment to the right patient at the right time, have them be active and informed partners in healthcare, have them improve quality of life, and improve cost effectiveness of the healthcare system. Now, those are all very valiant, but we wanted to get their opinion. Are we on the right track? Are we doing the right thing? And so what we did was we created a plan. And then we cold called some partners. We cold called some agencies. We cold called some PFAC members and said, hey, we're doing this grant. Would you like to comment on it and tell us, are we on the right track? And so we presented our ideas to them, and they gave us feedback, and we took some of the feedback and incorporated it and then submitted the grant based on their feedback. Not how I would do it today, but that's kind of how we waded into this. And they gave us great feedback on what we were looking at, and so we're really important at that and for getting the grant. So we got that money and we began to examine patient-reported outcomes and how they are related to the outcomes that we get for treatment of common GI cancers. And the first thing not the first thing we did, but the second thing we did, but I'm going to present it first as if we did this first, was work by Alison Mahar. She's a PhD at Queen's who has an equity focus, and she said, what you have to understand first is, who are you measuring? Who is reporting these outcomes? What are we collecting here, and who are we not collecting data on? And interestingly, CCO actually never really looked at this. They knew that only 60% of patients were screened, but they really didn't sit down and say, what groups are not being screened and why? So men are actually more likely to go to the kiosk and fill out the forms. Patients who are younger, that makes sense. Patients who are rural, so if you're inner city, you're actually much less likely to fill out an ESAS, and that's probably because our two bigger cancer centers don't do a great job with their ESAS reporting rates. If you're Canadian as opposed to immigrant, if you have a lower comorbidity status, and if you're higher socioeconomic status, you're more likely to fill out this form than not. Keep these in mind because we'll talk about symptoms in a minute, and there's a strong correlation. So this is work done by Dr. Bubis, who's a surgeon now in Winnipeg, and he looked at just kind of overall 30,000-foot view of ESAS in the province. And surprisingly, no one had looked at this. Now, at this point in time, there's about 3 million PROMs within the database. Currently, we have about 5 million recordings. So one of the largest collections of patient-reported outcomes in the world, and certainly one of the top collections of cancer PROMs in the world. And we looked at patients within the first 365 days. We excluded everyone who passed away from cancer or any other causes because we didn't want the end-of-life issues to be confusing us, and this was our first big data set. We looked at 120,000 patients from 2007 to 2014, which is about 750,000 ESAS scores, so a lot of data. This surprised us, but probably shouldn't have, because if you look at any other set of PROMs, everyone says the number one thing for arthritis or renal or cardiac or cancer is tiredness. So this is the number one problem that patients reported. Next is lack of well-being, and then these are the rest of the PROMs. I'll draw your attention to the dark blue line. That's anxiety. That goes down really rapidly when a patient comes into the system and gets a plan. So the faster a system can work to get a patient a plan and treatment, surprisingly, the faster the anxiety line comes down. The bottom blue line is nausea, which is something that everyone classically associates with cancer, but really not that high of a score, and it doesn't bump. So you can't tell when people start chemotherapy or stop chemotherapy based on this nausea score, because we're actually fairly good at controlling it most of the time, luckily. We also looked at symptoms by stage. This is a lung cancer cohort. The higher the stage, the worse the symptoms. Not surprising, but important to know so that you know who to give the most support to. And this is looking by disease site. This is also by Dr. Bubis. So everyone can tell that one of these lines is not like the other. This is head and neck cancer, which is that big bump. And so immediately we said, we need a head and neck surgeon on our team. Let's go find somebody. So we this is work that Catherine Adebayo did. She's a family practice doctor. She was working with the team. She's the first author. The second author is the head and neck surgeon. This is a bump from chemoradiation. So you can see the little dotted lines are when radiation starts, chemo starts, and radiation ends. And that's that bump. This is chemorads for head and neck cancer patients. Tony Iskander is our head and neck surgeon on the team, and he said, I just finished a paper looking at ER visits and hospitalization, and 1 in 2 patients with head and neck cancer shows up either to the ER or to the hospital during their treatment. 1 in 4 ER visits require admission. They're really sick patients. And we started thinking, what if we brought together this ER data with our PROS data? So Chris Noel just finished his PhD looking at this, and no one will be surprised to find out that the worse your symptoms are, the more likely you are to show up in the emergency department. Actually, it's the strongest predictors, those little red dots across the top, which is a ESAS score from 0 to 10. You can see that this is more important than anything else in terms of predicting who's going to come to the emergency department. And Chris did a fantastic third part of his thesis, which was patient interviews, conducted during the pandemic by Zoom, talking to the patients about their feelings about the ESAS system and how the cancer system had supported them with their symptoms. And then there was obviously a strong theme of COVID overlaid into his research, but so he combined qualitative and quantitative and really brought the patient voice into his thesis in an amazing way. This is another study that we did. This is Julie Halle. She's also a surgeon. There's a lot of surgeon researchers on the group, so it's great to see them doing this. And she looked at depression scores, and so a high depression score is greater than 2. So we looked at patients across the cancer system who had a score of 2 or more to see if there is evidence of intervention. There's things that we can measure and there's things we can't measure. So we measured palliative care assessment, psychiatry, psychology assessment through OHIP. We obviously can't find private pay. Social work referral, antidepressant therapy. I also can't tell what family doctors did in the middle of this, and obviously they're critical, and I can't tell the nursing interventions or if the oncologist sat down and had the conversation. These are the things I can measure. And this is what happened if you had a high or low ESAS score for depression. The percentage of patients who saw psychiatry or psychology was 2%. We're probably not doing our best work here as a cancer system. The percentage of patients who saw palliative care, 17%, and markedly higher if you had a high score versus a low score. So the scores hopefully are helping identify the patients who really need this. But I'd say as a system, we can do much better. And we're working with our teams in psychosocial oncology about this. If we intervene, so for any of the interventions, if we did intervene, the chance that the patient got better, which is the green bar, is much higher than the chance the patient stayed stable, which is yellow, or got worse. So intervening here is really important. Finally, we began to look at symptoms at the end of life. So the part of the cohort we didn't look at the beginning of the study, and we studied almost 40,000 patients who died from cancer from 2010 to 2016. This is about 100,000 ESAS scores. Over half of them had severe scores. There's a few very terrible things about this data. Patients who had worse scores were female, elderly, high comorbidity, urban, immigrant, lower socioeconomic status. Those are the ones who had high scores. The exact opposite of the group that actually reports their scores. So people who are less likely to report their scores as a group are more likely to have high scores. So clearly we have some work to do there. This is what the symptoms look like around the time of death. So you can see this is 6 months prior to death. Over here, this is right before death. Symptoms go up tremendously. I'll draw your attention to this little bitty numbers right at the bottom. That's the number of patients who are getting an ESAS. And now remember, this is pre-pandemic. So to get an ESAS, you have to walk into the cancer center. So the beginning of this cohort, we've got 4,403. At the end of this cohort, we have 5,748. So basically, your entire cohort is walking into the cancer center within the 14 days before they pass away with tremendously terrible symptoms. They're probably sitting in my waiting room or someone's waiting room for 2 to 3 hours. I think this graph shows that we have failed patients. And I talk about this a lot at CCO. But basically what this graph means to me is that we're failing. If you look at subgroups, this is a subgroup of pancreas cancer patients. We overlaid the same lines. It's not when you start the chemotherapy that you start to feel bad. It's when you end the chemotherapy that you start to feel bad. When they started the chemotherapy, the scores don't bump. I'm a surgeon. Patients come in. They're not afraid of me. I do Whipples. They're not afraid of me. They're afraid of Dr. Chan. They're afraid of the chemotherapy, and they're afraid of the chemotherapy symptoms. And I tell them if you can go through a Whipple, the chemotherapy is much easier. But they're very afraid of nausea and how they're going to feel on chemo. the symptoms don't bump when you go on chemo. In fact, Kelvin's got a paper that says sometimes patients actually feel better when they start the chemotherapy. That's information we need patients to understand, and that's information we need to understand as providers. What happens when you come off chemo? The trajectory is pretty predictable. The symptoms go up. I think most of the conversations with medical oncologists at this point, when you stop the chemo, is why don't you come back to clinic in a few months? We'll get a CT scan in 2 to 3 months and see how you're doing. I think if you look at this data, I could tell you that the timeline should be a little bit faster, and maybe we should say, why don't we have you talk to palliative care now? You're feeling okay now, but at some point over the next few weeks, we know you're going to need some more support for something. Let's go ahead and get that into place. So that's a systems issue that I work on. So that was the 2016 grant. The amount of patient engagement on the reports was low. So we had patients engaged to start the project, and they advised on the trajectory, and then off we went. Things that we worried about time commitment from the patients, quite honestly. We didn't really have a mechanism to pay patients to be engaged in the process. And we were worried about understanding of the data and the process, and we were worried, frankly, about bringing patients in and them not understanding the process and the barriers to the data. And there were a few groups that we tried to work with. We tried to work with some patients who had previously done research, and some of those worked better than others. Some of them really didn't work at all. But the amount of patient writing on the papers is really pretty limited in that data set. So about the midpoint of that grant, I was asked by Bilal Al-Kafaf, who's a surgeon in the UK, to work on the gastric cancer core outcome set for RCTs in the UK. And I'm very inspired by his work, and he's integrated within the COMET group. So he did the gastro study, which was looking at a core outcome set for gastric cancer surgery. So overtook a very large project, did a systematic review, did a Delphi process, and then stakeholder engagement. A lot of patient engagement here, and I watched how he engaged patients. It was very different than the way we had engaged patients in the past. So they did a systematic review for gastric cancer surgery. That is why all these outcomes look surgical. But you can see that number one's way down here. This is adverse events. This is what surgeons worry about. So this is research that surgeons came up with. So this is the literature, and this is what surgeons put onto trials for gastric cancer surgery. You can see number 3 is patient-reported outcomes. There's barely a blip there. Mortality is there in the middle. Some of the more interesting things are the different ways everything was defined. So adverse events was 240 unique terms. Short-term mortality, 15 different definitions. How can you even come up with 15 ways to say short-term mortality? I don't know. And then long-term survival, which arguably is the key thing for any oncologic trial, was only reported in 41% of the trials. Very few patient-reported outcomes here. But this is the status of the literature, and these are trials made by surgeons and researchers. So this is surgeon and researcher informed, not really patient informed. So he took the 498 outcomes identified in the literature, added to this patient interviews to get the patient's perspective. What would you have rather we looked at rather than anastomotic leak? And added to this, and then did a Delphi survey. So the first 2 rounds were done on SurveyMonkey, and then the consensus meeting was March 7th, 2020, so a few hours before the world shut down. And they list the ones that they chose. There was a tremendous discussion and a really interesting discussion between the patients and the providers at the consensus meeting about adverse outcomes. And what adverse outcomes, what I learned was what adverse outcomes means to me as a surgeon or me as a researcher is very different than what adverse outcomes means to patients. And so we really need to better define that, because what I see as something bad happening, patients don't see it that way at all. And in many ways, if you get out of the hospital in 10 days versus 7 days, that doesn't matter. If they're minor complications, it doesn't matter. Obviously, if it's something larger, like being in the ICU or critically ill, that matters. But a few bumps and hiccups along the way, that was not their primary concern. And I think the key part of this is this conclusion that it needs to involve the views of all key stakeholders, including patients. And really, a lot of the literature to date does not include this. So if you want more information on this, you can go to the Comet website. They have a tremendous amount of information, including basically a cookbook of how to do this and how we can do better, how to create core outcome sets. And what I would say for funders and for people who are running clinical trials is that if an individual team is coming up with their own outcomes and they don't say, we have reviewed the literature and here's the core outcome set for this disease and this process, we shouldn't allow other groups to just make more definitions, because this is not helping any of us, because as somebody who does meta-analyses, you can't combine those results at the end. And this results in a lot of waste in resources and waste in research. So if you review oncology trials, there's about 25,000 outcomes that only occur once or twice. You can't combine any of those for meta-analyses. Cochrane reviews will say the same thing. Most of the time, you can't actually obtain the data for the key findings. You can't obtain the data sets if you want to do an individual patient meta-analysis. And if you look at different RCTs, over 10,000 RCTs for schizophrenia, there's over 2,000 different measurement scales. We need to tone this down a little bit somehow. I don't know how. That's your job. Not my job, but this is something that funders can maybe help rein this in. So that really informed what we did next. And we were supposed to write this in early 2020. It was actually due in April 2020. It obviously got put on hold, which I think was probably the best thing that happened to this grant. Because it was put on hold and then we all had a lot of time to think about it. And Zoom technology took off, and so the team actually cohesed better following the pandemic than it did before. And we came up with a very strong team. And a very strong group of patient advocates are engaged in this grant from the beginning, from the very beginning. And this is the first sentence of the grant. Is Julie DeLemans, who is on someone's team. I saw her. Yes, she's amazing. She's simply amazing. And what she said was, when I was diagnosed with cancer, the emphasis was put on what the doctors felt mattered most to me, surviving. But I wasn't informed fully about the consequences of treatment, especially regarding potential psychosocial issues. And I wish I had been. And so this is a grant focusing on how to get this data back to patients. And so what we're looking at is, number one, if you're doing real-world evidence, what is it that GI cancer patients want? Because I can tell you what I can report on and what Kelvin can report on and what Winston can report on, and that's what's available in the databases. But we actually cannot tell you what the GI cancer patients want as outcomes. So step one is interviewing patients and a Delphi methodology and a review of the literature to see what is it that patients actually want real-world evidence to reflect for GI cancers, and Julie Halle is leading that, and that is going along quite nicely. We have a lot of patient interviews. We've just finished our systematic review, and the Delphi will happen next year. Number two is what I'm leading, which is model creation at ICES. I can tell you some of the things that we're going to look at. We're going to look at survival because it's oncology trials, and we need to do this. We're going to look at days at home because we already know that that's one of the things that patients focus on, and we know that from the review of the literature, and that's not a classic indicator for cancer outcomes. And then we're going to look at patient-reported outcomes. We'll validate them, the nomograms externally in Manitoba, and then we're creating predictive models, and we're working with Project Big Life to get this available on the web so that patients can go in and say, I have pancreas cancer, I'm stage 4, what can I predict my next 6 months will look like? How many days will I be at home versus in the hospital? What might my symptoms look like? To get the data back to the patients, which is something that we've been wanting to do for a while, but this is a very large, ambitious fairly expensive project that fortunately CIHR is sponsoring for us. And so there has to be patient engagement in all of this. And so the patient sat down with us at the very beginning. We obviously had a bit of time on our hands. The grant got delayed about 4 times over the course of the early pandemic, so we kept making it better and better. The patients are working on each objective, and we have very frequent meetings. We use the public and patient engagement tool to score patient engagement, although this is not a very in-depth. Are you pretty happy? They're on our team. We get along. I think they're fairly happy, but this is probably a little bit of a biased tool to ask people who are actually on your team. More important, I think, is, and this is a big change from the first grant that we did, which is how to pay the patients, especially they're putting in a tremendous amount of time. They have full-time jobs, they have full-time families. Some of them run agencies on the side, and then some of them also are still dealing with their cancer diagnoses. So having them appropriately compensated is really critical. And I think it's really important that CIHR allows for this and encourages this. And I would say from funding agencies, if a team doesn't have this written into their grant, then you need to question how serious they are about what they're doing. So then this is my most recent grant, and Carol and I were discussing this the other day. So this is the 2022 Canadian Cancer Society grant. So I received an email from the Canadian Cancer Society, and it said we're going to have a grant, and it's for orphan cancers. And I said, golly, I treat an orphan cancer. I treat a few of them. And then I thought, golly, I'm really busy. And I kind of filed the email over to the side, and we all know what happens next to that email. About a day later, I get an email from my patient partner who says, what are you doing for this grant? It wasn't like I didn't really have a choice in the matter. What are you doing? And I said, I'm not sure. So then the next email comes. Team, here are the dates. When are we meeting to talk about this? And so this is the engagement you want from your patients, that they call you and say, you're a researcher, get to work, do something for us. So I said, fine, we will meet. And so we brought the team together. You come into these meetings, you have to come into the meeting with a plan. I'm a surgeon, I have to come to work in the morning with a plan. So I came into the meeting with a plan, and I knew what the grant was going to look like, right? But we have the whole team, we have the patients, and I kind of have in the back of my mind what I want to do for the grant. And I said, well, what do you guys want to do for the grant? It's completely different than what I wanted to do, but also way better. So this was not the idea I came in with. This is the idea that they came in with. And I said, yeah, we can do that, and that'll be better than what I was thinking of. Thank goodness you guys are here to give us the ideas and to tell us what's really most important. And then the second cool thing that happened with this grant is it's actually led by a caregiver. Monica Ewan is one of our master's students at U of T. Her mother had gastric cancer, and she came to our team by saying, I want to help. How do I help? And I wasn't really sure how she was going to help. She wrote this grant. So this is kind of how I see patient engagement having worked in my research team. So in the beginning, we made something. Sometimes it comes out looking a little bit like this at the end of the reviewer's process for all the journals. And we made something and we said, here is our outcome. This is it. Like, not even do you hope you like it. This is it. This is it. We've worked really hard. We can't make any more edits to this manuscript. Here is our outcome. This is probably not what anybody wanted from the patient world. May not even be what anybody wanted from the research world. But at that point in time, I didn't really understand how I could talk to a group of patients and say, okay, I got some flour and I got some eggs and I can make something. You tell me what you want it to look like. And so I really feel like some of the first things we did was, here's a cake. You guys want to help us decorate it, make it look pretty, and make it look better and more palatable. But really what you want to do is say, what do we want? Do we want a meringue? Do we want lemon? Do we want chocolate? Do we want multicolored? What is it that you want from us as researchers? And then how do we add all the right ingredients to get to that point? So I'll probably never make another cake that looks like this again. Fortunately, that's not actually my cake. So So I work really closely with My Gut Feeling, and Teresa Tiana is sitting down in the center, and Katie Kachakova is right there. They're both gastric cancer survivors. Christine Breston is here as a medical oncologist, and they're the ones who call and say, look, what are you guys doing? This is what we want. This is what we want you researchers to get your butts into gear and start researching now. How do we improve? How do we improve as researchers? I think a lot of it comes from the regulatory agencies. If this is not something that the regulatory agencies ask for, or the patients on the regulatory agencies say that this is important, it won't happen. And it's just like the knowledge translation question. It's just like the gender question. If you don't put it down as a, how are you doing this as a researcher, it's not going to happen, because you've only got 10 pages and you got to explain all the science, and unless you have that section that mandates how are you doing this, it's not going to happen. In terms of journals and other regulatory agencies, same thing. If all the journal editors said, we want to see a patient on every publication, we couldn't do that. We would overwhelm the system, or would we? So I think the important thing about the Canadian Cancer Society grant is they put patients on the panels, and patients actually led that grant initiative. And they were on the panels, and there was a Zoom call, and they really put the scientists through the ringers. How are you doing this? What are you doing? Why are you doing it? How's that going to help us? And I think that improved the quality of the science in that grant system. So we need to change the scoring system. We need to make sure that this is embedded and baked into all of our systems. If we're doing randomized controlled trials, I think we need to make sure that we're using core outcome sets so that we don't have outcomes that we can't use and can't combine, and make sure that they're patient-centric, and make sure patients have had a voice in those, and there are systems that are moving everyone towards that. And then, of course, insist on funding for patients who are embedded in these teams, because it's a lot of work and we ask a lot from them. Finally, I'm really glad you talked about diversity and representation. You spoke about that much better than I could. If you look at some of the PFACs, representation is a huge problem, because people who are on PFACs and people who are volunteering are a different socioeconomic status than people who don't have time to volunteer. So we have to make sure that we've got good representation. So then finally, I'll just thank my team, the researchers, the patients, the funders, Cancer Care Ontario, and my clinical teams. So I'll take any questions.
Two mics for anybody who'd like to stand up.
Hi, Natalie. What I haven't seen today, and also I was curious, is tracking social determinants of health. I think that's a little bit different from the EDI. Do you do that in your research?
Some, and probably not as well as other groups. So we do. So Dr. Mahar is an amazing equity researcher. She's at Queen's, so she's leading a lot of that work. We are looking at social determinants of health for colon cancer, actually, looking at screening, and then what happens to patients of different ethnicities, different immigrant status, different socioeconomic status in terms of their treatment and their outcomes. That is very challenging because we don't have racial information. And that's an interesting problem, because that's another thing where everyone says, we need this. CCO says they need it. Researchers say they need it. CIHI says they need it. CIHR says we need it. And CPAC says we need it, and we don't have it. And it's something that could be attainable if everyone just, with like COVID, we must do this trial. It gets started in 9 days. Right? If someone, and I think it would have to be a federal initiative, said this will happen and it will start January 1st, the system can turn on a dime if it wants to or needs to. But if everyone's assuming somebody else is going to do it for them, it's not going to get done. But if some group said January 1st it starts, it could be done. That is not insurmountable. Just no one has said that.
So remiss if I didn't say to you that you did a fantastic job, and thank you for sharing your story. Really, honest to goodness, from the bottom of my heart, you went forward, you looked at your failures, you said, what can we do differently? And I think that's excellent. The little story I want to tell you, I sit in one of the Institute advisory boards of one of 13 institutes at CIHR. I'm in the AMHA one, Institute of Musculoskeletal Health and Arthritis, because I have a lot of arthritic problems. And also during the pandemic, when you were learning your lessons, patients were sitting there, and AMHA is a leader in patient engagement, and their scientific directors have been phenomenal out of the 13 institutes in moving things forward, in my humble opinion, and it's to people before myself. But they have a group called PIRA, Patient Engagement Research Ambassadors, and these PIRA members actually co-wrote fully 100% patient-done patient engagement in research modules. And these modules are 30 minutes long, they're bilingual, they're available to anyone. We did them in the middle of COVID. It took us just under 2 years to create them, and they have been taken by over 1,100 people, and the vast majority of people taking them are researchers, followed by patients, followed by clinicians. And I say that the next thing that I would say about these modules is they met a need because a lot of people thought they knew, or thought what they were doing is what they knew when their heart was patient engagement, but as your story showed us, wasn't, not for anything malicious or anything. It just was not understood what it was supposed to be. Anyway, AMHA took them, and when they put a call out that was under AMHA's control for a CIHR funding project, two things came up. Number one, you had to have a patient partner, and number two, you had to have everyone in the team do the modules. So this way, people are coming together to get the training, to get the education, to get the understanding, to hear the stories, and to work together. And I, honest to God, look forward to the day, not too distant in the future, where almost every clinical trial has a patient co-investigator as well as the researcher doing it. So huge kudos to you and your team. Good job.
Thanks.
Thank you. Linda, may I ask you to just stay at the mic, because I had a question for both of you actually, is the distinguishment between a patient and a patient group, and how particularly the grant process is looking at that, how we need to be looking at that, how we should think about that.
I'll say the expert in explaining why patient groups, which are called, I think, patient advocacy groups, perhaps in the UK, honest to God, is Barry. I mean, he knows what he's talking about there. However, what I will say, having been on the board of different patient-led, CAPA is one of them, the Canadian Alliance for Patients with Arthritis, and also Fibromyalgia Association of Canada, is a few things. Number one, patient-led associations or disease-specific associations that have patients associated with them. So patient groups across Canada are utilized in a good way to do clinical trials in different areas, including clinical trials and care. So we actually, as part of the CanTrain project for Across Canada Needs Assessment, to get information more than just from researchers and clinical scientists, is looked at, CADIF had put together a group of about 50 or so patient-led organizations or patient organizations. We put it out to our work group and asked people to add to it. We now have about 70 different organizations, and we're asking them, what do you see is lacking in clinical trials? What do we need? What did you use? It was phenomenal. What training would you like? What are the challenges and barriers? What does patient engagement mean to you? And how would you like to be supported to be engaged? So I think clinical researchers, trialists, could work so much more with these groups that are literally, like you said, we're doing it for free over the backs of our disease processes and trying to move things forward, and would love to work with researchers and whatever it is, whether it's research, matching up researchers with patients, or ensuring that patients are also not just participants in research trials, but are co-partners in research trials. And I think there's a lot, numerous groups in every province and territories with every disease specific entity would love to do more on that. And we don't use it enough. So we have patients, and they're either participants or they're partners, but we forget sometimes about the patient organization, and they will continue the history on of the working relationship. At least that's the way that I see it.
Natalie, do you have any comments on that?
Yeah,
Excuse me.
I mean, we have had better experience with advocacy groups than individual patients. I think it's hard. It's hard to burden an individual patient with this level of engagement and this level of research, and they have full-time jobs, they have other things they're dealing with. So I think we've had a better time with advocacy groups. I know other groups have had a better time working with individual patients. It's like your relationships with any of your research. Sometimes it works with other collaborative groups and sometimes it doesn't. And just because it doesn't work when you reach out to the team in the Manitoba team is great, but if you reach out to the team at another hospital and things don't work out well, it doesn't mean that you don't try with a second hospital. There was one group we reached out to, and they didn't understand what we were talking about at all. And so I said, well, do you have anybody who's in research? And they said, yeah, we do have somebody in research. And so this person was a survivor who was actually a researcher who actually had done big data. And I thought, this is the perfect partner. Like, this person can understand what we're doing. And I talked to them, and they're like, but why do you want me to be on your papers? I'm like, because you can help us and advise us in a way that I can't, because you've had this cancer. And they didn't understand at all what we're doing. And it was an American group, and so maybe that was I don't know. They didn't understand why I was reaching out to them. So that did not work. But then we reached out to another group, and we found fantastic partners. Fantastic. So sometimes it works and sometimes it doesn't. Yeah. And I guess just don't give up after the first one doesn't stick.
Great. Thank you so much, Natalie. I know you're going to be here tomorrow as well. If people, I'm sorry, friends. Did you want to ask? Yeah, how about one more question, and that will be the last one, and then we're going to ask Barry to close the day.
So fantastic presentation, and thanks, and to you and Barry or Linda. But a lot of what you said was about about the huge contributions that people with lived experience can make to, for example, outcomes, selecting the right outcomes, and then the rest of the design and everything. But I don't know, maybe I missed it, but we've talked less about the priority setting in research. And so I wondered if you could address this. And obviously, before you say how patients with cancer, with a specific cancer, can talk about let's say, ENT cancer, and we'll, set priorities for ENT cancers. I wonder how patients who come with their personal experience of their illness or how different patients or people can be involved in the more broader exercise of priority setting across health problems, perhaps, because it's very easy to mobilize patients and people with experience who are passionate for obvious reasons, but mobilize, one group against the other, and to lobby, diabetes versus stroke versus cancer. And so I wonder how that could be improved upon, perhaps.
Yeah, I think historically, like with the gastric cancer surgery outcomes, and those were set by surgeons, and so they're outcomes that matter to surgeons. But they're also measurable outcomes. When we wrote the grant asking for a core outcome set for GI cancer patients, one of the reviewers said, but what if they ask for something that you can't get in your data set? And we said, that's kind of the point. Because it was hard to write the grant, because the grant says we're going to ask patients what they want as outcomes, and then we're going to find the outcomes. And a pretty savvy reviewer is like, but what if they ask for something that doesn't exist in ICES? And then what are you going to do, smarties? And at that point we said, well, look, we've got Giant Irish on the grant. We've got other people at CCO. They will help us figure out our way out of this problem. And it would be great to come up with a priority setting for diseases, because you're right, you cannot pit the different diseases against each other, because gastric cancer will lose out to breast cancer every single time because we don't have as many patients, and our patients don't do as well. So you can't just have the most vocal, most involved advocacy group setting priorities. So that would be a fantastic project for someone to do, is to talk about what are the global things that should be addressed, and as a Canadian society, what should we be thinking about in terms of outcome and equity and provision of care? Because I do think the pandemic certainly uncovered a lot of problems with equity and a lot of problems with priority setting. And we had to set priorities pretty quickly, mid-March, about who we were going to take care of. because he came crashing into the emergency department and into the ICU. There were a lot of very, very deep conversations about, when we get to this point where New York or Milan is, what are we going to do when we have to start rationing ventilators? You guys don't operate on any cancers. Just stop. Like, we stopped operating on cancers. How do you tell your cancer patient, I'm sorry, we're not operating on you? And it's because it's actually really not very safe for you to be in the hospital, but we actually don't have any ventilators for you. We'll get back to you in a week or two. Maybe things will be better. So I think having that conversation outside of a crisis would actually be really important. I'm not sure who the right person is to lead that, but that would be a great conversation.
Thank you, Natalie, very much, and we'll look forward to speaking with you again tomorrow.